Okay, so as people are logging in, I got all the prescriptions graded. Everyone did pretty good. Just a couple things that I can recall that I noticed. Make sure when you're writing out the quantity for a controlled substance, especially like a C2, you need to have the textual amount in there. So if you're for like 108 mLs, you need to write 108 in actual text. You don't have to do that for every other number that comes up in that script, but if you write it out in text, that's totally fine too, because it's really hard to screw that up, right? Again, watch out for trailing zeros. You don't want those. Make sure you include leading zeros if it's less than 1. So for instance, not writing 0.6, but writing 0.6. I think what else? Make sure if you want to be more succinct in your writing, that's totally fine. So you don't need to include every single set of instructions possible because you're going to be talking to the patient. You're going to educate them. The pharmacist will do some education as well, usually for like new scripts like a Humira pen or something like that. So you don't have to write specifically, you must inject into the to the thigh or the abdomen, blah, blah, blah. Make sure to rotate sites. Make sure to use new needle every time. You don't have to include all of that. It's totally fine for like a Humira. Just say inject 1 pin subcutaneously every other week, or Q14 days, or every other Monday. Something like that would be totally fine. Quantities were generally fine, but when you're doing like a pen, typically just write the number of pens that you need to dispense. Writing like a pack or a kit may be ambiguous depending on kind of what your who the pharmacist is you're working with and things like that. So it may be confusing. So it's good just to write the number of pens. And then typically you want to write for at least a month's worth to cover those patients. So for instance, with like the Victoza, notice what was the dosing like. Or like you dose like for 0.6 for the first week, and then you would increase it to that 1.2. Since they're going to be on that 1.2 thereafter, you can just write the to cover for that amount for the month. So again, 2 pens was generally enough to cover most of those scripts. Anything else? Otherwise, everyone did pretty good. All the calculations I saw were good. I don't think I saw anyone that killed anyone with the high set liquid. Some of you were very generous. And yeah, and again, read the assignments. Make sure like for dosing for 5 days worth, just write for 5 days worth, right? Okay. Where's Kelly? If we knew that answer, we'd know a lot more about the world, right? Okay. Any questions about the material for the test? I'm sure everyone's studying diligently during their spring break. How was spring break? Good, relaxing? Somewhat? You're like, there's some memories I'd like to forget. Maybe things that have been forgotten unintentionally. It's okay. Is that everyone? Discourage teens, but I understand sometimes that happens. Okay, I'm gonna go ahead and get started. Start a few minutes late anyway, so again, you can still log in. That thing should be there. All right, let us begin our Pharm 2 test 3 review. We're almost done. We're like almost 3/4 of the way done. Yay! Okay, which medication can be administered via the endotracheal tube to premature newborns with respiratory distress syndrome? Dexamethasone, I think it's caffeine, Baractant, Lumicaftor, Ivacaftor. Very good. Yes. So that is correct. So Baractant or Survanta, that is a like a recombinant sort of surfactant that we can administer. Remember how you actually give that? What is kind of the unique thing about how you administer that drug? Yeah, you need to position them in different spots, right? So you remember you do in several aliquots, so that way you can reposition them, make sure you kind of cover the whole lung to get some good coverage there. Why is dexamethasone not correct? Yeah. Yep. So we give that to mom prior to delivery to try to help stimulate surfactant production. What else could we use? Betamethasone was the other one that was on there. Theoretically, any kind of glucocorticoid could do this. Those are the more common ones you're going to see. So dexamethasone is given to mom beforehand, not given to the baby, definitely not given via the endotracheal tube, right? What is Lumicaftor or Ivacaftor used for? Or Combi? CF. Yep, CF patients, right? So that helps to generate better those CFTR channels, and it helps to surface them onto the cell surface there, right? Good, so there's that. And then caffeine, what do we use that for? For happiness, perhaps. So we use that more for premature neonates, or just really any neonate who's having issues of apnea, right? So that helps to stimulate the respiratory drive, and that is used for that particular case. You might have patients who develop RDS that go on to having apnea issues, but it's not necessarily always going to be that link there. But yeah, so caffeine is used for that purpose. Fantastic. Exam Master LOL. Okay, which of the following drugs can be used as a mucolytic in a CF patient? What is a mucolytic? Breaks down mucus, absolutely. What can we use? It's important to realize why we're using the drugs we're using for the CF patients. What do we think? And yeah, there are 2 correct answers on this one. Again, won't be that way on the test, but I like to keep you guys thinking on your toes a little bit here. So anyway, what is azithromycin used for in a CF patient? It's more as an anti-inflammatory, right? So we're really not using it specifically as an antibiotic. We're using it more as an anti-inflammatory agent. We see that kind of helps to delay some of that kind of the progressive lung disease that happens with those patients. And so if you ever see someone getting it like Monday, Wednesday, Friday continuously, that's what they're using it for typically. It's usually a CF patient. Tobramycin, what are we using that for? So that one is as an antibiotic. What is it used for specifically to try to kill? Pseudomonas. Yeah, remember Pseudomonas is like a really big problem for these patients. They develop what type of Pseudomonas? Remember that you get that extra special version? That mucoid Pseudomonas, right? So again, they're even more difficult to kill with normal antibiotics. And so how do we normally give that tobramycin, say for like kind of chronic use? Or the different routes we could use for a CF patient? The inhaled route, right? So again, what's the benefit of using inhaled antibiotics? Very high concentrations right there in the lungs. They don't really get a lot of systemic absorption. So again, you don't have to worry about things like kidney issues or ototoxicity, things like that. So yeah, so we use tobramycin as part of their pulmonary regimen to try to make sure we can get that Pseudomonas. And when would you want to give that tobramycin? Like first, last? Because remember we have like the chest physiotherapy we're doing. We're going to have some mucolytic agents we're using. Things like bronchodilators like albuterol, and then we have our antibiotics. Probably want to use that last. Why? Yeah, good. So again, we're trying to get them to break up all that mucus, try to get it out, right? So that way you can kind of cough it up, and that way you have better penetration, better coverage of the lung that happens there. So normally antibiotics tend to go last in those patients. Okay, so looking at mucolytics, we have things like 3% saline. So is that hypertonic, isotonic, hypotonic? That's hypertonic, right? What is isotonic saline? 0.9%, right? So 0.9% if you're writing it on a script, right? You don't want to give 9%. So 3% saline is good because that, again, is hypertonic, helps to break down that mucus. And then what about that dorniase alpha? Actually breaks down the DNA for some of those like inflammatory cells that are kind of like lung caps or helping to gunk up all that mucus and whatnot. So dorniase alpha can kind of help to act as a mucolytic. Very, very expensive because it's a protein we have to produce. Anyone remember what else we can use potentially? Smells like rotten eggs. Well, it contains a lot of sulfur, but it's mucomist or acetadote. We'll talk about that in the tox section a little bit later on because we normally use that for acetaminophen poisoning, but you can also use it here as a mucolytic. Remember I said like my first job as an intern at the hospital was also having to take the big bottle of acetylcysteine and having to put it into small bottles for nebulization, and it stunk to high heavens, and so I got to smell like rotten eggs for like a while. That's good summer. Okay. Anyone want to guess what the random trivia that I chose, what the theme is going to be? We did heavy metal last time. I think we did video games before. Anyone want to guess? Legalized skooma. I agree. I don't know if how many people actually know what that is. Okay. My Skyrim players. I'm actually going to do not rappers. I don't know that. Up on rap. It's actually going to be collective nouns for animals. So I don't know when that's going to show up, but so we'll see. Okay. Which of the following is most likely adverse effect of using prazosin mini press for BPH? First question is, what type of drug is prazosin? And people might say prazosin, I say prazosin. Right, so dizziness would be the correct answer here. So what is the mechanism of action for prazosin? Alpha agonist or blocker? Blocker, alpha 1 blocker, right? So again, this is going to be mainly working on the blood vessels. You're going to see this also work on the prostate, because again, that helps with that kind of that squeeze that happens there, right, on that tissue. So a lot of side effects associated with these earlier drugs, earlier alpha blockers, related to that alpha 1 antagonism, right? So would it cause bradycardia? If anything, it would cause tachycardia, because right, because if you decrease your SVR, what needs to go up to compensate? Cardiac output, right? So you have to increase the heart rate. Usually, it's going to be one of the first things you're going to see there. So tachycardia is actually one of the things you can see in addition to hypotension, right? Testicular atrophy, what would cause that? Yeah, 5-alpha reductase inhibitors like your finasteride or dutasteride, that would be more likely to cause that because you're decreasing DHT levels there. Gynecomastia. Yeah, it's going to be more seen with things like spironolactone, but it's going to be more seen with things that help to decrease the amount of testosterone you're actually able to produce for those patients, right? So again, that would not be correct. This would be more like kind of the hormone-acting sort of agents. But dizziness, why do they get dizzy? Orthostatic hypotension, right? So again, they stand up, they get dizzy, and they fall down, they break their hips, and all kinds of bad stuff. So dizziness would be the more common thing you're going to see with a drug like prazosin. So how do we get around that? Yeah, if you want a very selective alpha-1 blocker, so what's a good example of that? Flomax or tamsulosin, right? It's an alpha 1A blocker. So again, as we get more specific, it helps to mitigate some of these side effects we see with that, right? Good. All right. Inactivated vaccines cause which type of immunity? Passive, innate, booster, or active? Correct. That produces an active immunity. Why is that? Yeah, it actually triggers your own immune response, right? So you're producing antibodies against this particular, whatever the pathogen happens to be. So what would be an example like passive immunity? Breast milk is good, right? So mom's passing on antibodies to a baby. We do this when we give things like IVIG to patients, have like primary immunodeficiencies. Again, what's the kind of the drawback of passive immunity? Temporary, right? So something's going to last as long as antibodies are floating around because the patient's not making them themselves. How about innate? What's an innate immunity? You think like your skin is a pretty good, things are like kind of permanent barriers against, pathogens. So boosters not really a type of immunity necessarily, but just remember that within activated vaccines, you're more likely to need boosters for that because again, we don't get as good of a durable response as you would see with something like a live attenuated sort of vaccine, right? So again, something like polio, we have live attenuated versions of that. You typically don't have to get a polio booster throughout your life, but things like tetanus, you certainly do need to get a booster, later on in life or every 10 years, whatever happens to be, right? Okay. Wrong mouse. Right. Which of the following is most appropriate for a 4-year-old male to prevent constipation? So like kind of an everyday sort of med they can take to try to prevent kind of intermittent constipation. All right, good. Yep. So kind of think about these agents and kind of their onset of action, how quick these are going to work, right? And if you need something that's going to help to prevent constipation, not necessarily treat active, they're having acute belly pain because they're constipated, like your kind of modality of treatment changes a little bit. So for instance, like manganese hydroxide, that's going to cause some pretty significant diarrhea kind of like right off the bat. It works very, very quickly because it's an osmotic sort of laxative. So that one's good if you're having kind of an acute episode of constipation, not good for kind of chronic everyday sort of use, right? Who might get a glycerin suppository? Usually babies, usually like infants are going to be better to get glycerin suppositories. They tend to, because we want to try to limit use of some of these other ones, for instance, like the sodium phosphate enemas. And why is that a problem? Yeah, I can see electrolyte imbalances, right? Enemas are typically good for like really kind of quick clean outs. You don't want to use that every single day. And you could see kind of chronic hyperphosphatemia associated with that, which is why you probably would not want to use it every day plus it'd be kind of inconvenient to have to use that sort of thing every single day. However, something like Miralax is very good because you can kind of use that every day. A lot of patients will be put on that kind of as a prophylactic to kind of kind of head off any constipation from developing. Similarly, you could use what else? It's like fiber supplements, might be good to, kind of throw in with their juice or something or whatever, their water. Those are good. You could also use Miralax in a bigger dose for a clean out. So for instance, we had a bunch of GI admissions that I was seeing yesterday. They are all getting these really big doses of polyethylene glycol. You know what you call it when you get like the big jug of polyethylene glycol? Go lightly, right? And there's nothing light about how you're going when you're on Go Lightly. So yeah, so if they're coming in for like a bowel clean out or if you're getting like prep for surgery or something, they might do a very big dose of that because again, it can help to stimulate kind of evacuation of the bowels pretty quick. However, you can use these lower doses, like you ever say 1 cupful or 1 capful a day. That's usually for just kind of chronic kind of prevention of constipation. Good. All right. What is the collective name for a group of crabs? Is it a hood of crabs, a consortium, a cloud, or an audience? Please do not Google this to cheat. You get no points for this anyway. Because that's what I did, just Googled it, and it's the first site that came up. So. It's actually a consortium of crabs. You find alliteration is usually kind of the safest bet to go with some of these. So in case you're ever curious, you see a bunch of crabs walking across the street. It's a consortium of them. Yes. Never say I didn't teach you anything. Okay, patient receives an inactivated vaccine today. Which of the following are true? They can receive a live vaccine next week. He can only receive other inactivated vaccines today. He needs to wait at least 6 weeks before the next dose, or if he misses his next appointment, he must restart the series. So you're getting an inactivated vaccine. All right, so this one's correct. So he can receive a live vaccine next week. When would this not be true? If he got a live vaccine today, he could not receive a live vaccine in another week. You gotta wait at least, how long? 4 weeks. You gotta at least wait 4 weeks. Otherwise, you might see diminished efficacy of the second one that you administer in that case. Because again, the immune system's kind of still ramped up from the first one. He can only receive other inactivated vaccines today. Why is that incorrect? You can get anything at the same time, right? So you can receive live and inactivated at the same time. That does not show any kind of reduced efficacy of the vaccines. If he misses the appointment, he must restart the series. Not correct. Again, typically you want to err on the side of going too long between doses, rather than going too short, right? So again, you want to at least wait that 4 weeks, not really any sooner than that, but certainly if it goes out an extra month or something. Now, if it's like 10 years, probably want to restart at that point, right? But you can go a little long, that's fine. And then needs to wait at least 6 weeks before the next dose. Incorrect, because you can wait a minimum of 4 weeks, right? Now, with inactivated vaccines, usually in those series, they'll wait usually between like the second to last and the last dose, usually like a period of several months, to make sure you get that kind of nice little kind of booster effect at the end there to really get a good kind of established immunity. But again, the minimum amount of time there is 4 weeks. All right. What is the ratio of elemental calcium in calcium chloride to calcium gluconate? From the ER lecture. I mention this because I've seen medication errors happen here where you can really screw this up. You remember they look almost identical. I should have included a picture. Remember, what's a larger molecule, gluconate or chloride? Gluconate, absolutely. They both come in that 10% solution. They both come in 1 gram in a vial. Because again, when are you going to be using this? What type of situation? Just in an ER setting. Like someone's actively coding, right? Or they have a K of like 7 and you need to treat that hyperkalemia. Right, so you're usually moving pretty quick here. So yeah, so it's a 1 to 3 ratio. So for instance, you know, if I was going to dose my calcium chloride at 10 milligrams per kilogram for the gluconate, it would end up being what? Probably like 30, like 20 to 30 usually milligrams per kilo at that point, right? So again, keep those kind of ratios in mind because you can screw something up, and if you have to accidentally give either a third less than what, or a third of what you wanted, or give 3 times as much as you want, it can be deleterious to the patient either way. What's the problem with giving calcium IV? Very irritating to the vein, especially the calcium chloride. So we like to use as more dilute solution if we can. We like to infuse it over a long period of time. What's another way as far as like where the actual catheter is that can mitigate some of those problems? Central access, yeah. So again, if you can kind of dump it out into the vena cava where you have a lot of blood flow happening all the time, that helps to dilute it very quickly, and you see a lot less thrombophlebitis associated with that. So central access is always preferred. However, if you have someone kind of rolling in from EMS, are they going to have central access in the ER? Negative. No, they're going to have peripheral IV. If you're lucky, maybe an IO potentially, depending on the patient. So yeah, you're not going to have that kind of good access there. Okay. All right, in PEDS, which of the following means of drug dosing is least sensitive to the extremes in weight? Is it weight-based dosing, body surface area, height-based dosing, or age-based dosing? Which of these would be least likely to give you an error if you had a kid, either a very, very small kid or a very large kid? I've had like a 12-year-old that only weighs like 30 pounds, 30, 40 pounds, like, because they, depending on what their disease states are, they can be very, very small. Or I've seen some pretty large kids as well. 10-year-olds are like, 100 kilos. Yep, so body surface area is actually the least sensitive to extremes in weight. Why is that? Because it factors in weight, but also factors in the height of the patient, right? So again, by using both of those parameters, it helps to mitigate some of those extremes there. Weight-based dosing, you can see some errors there, especially if you have someone who is very, very large or very, very small, because again, they can have differences in like adipose tissue, they can have differences in lean body mass and things like that that can affect volume distribution. You can see errors associated with, or see adverse effects associated with that. Why is age-based dosing a problem? Kind of just what I mentioned, right? So you can see big extremes in weight there. Height-based dosing, when do we ever use that? I showed one example of it in like the ER lecture probably. That prazosin tape we mentioned, you kind of like lay the kid upside, that would be very sensitive to the weight of the child, and so that could be very prone to errors potentially. It'll give you a range, like, so the kid's, if he's this tall, he's probably between these two weight ranges, right? So again, that can be very kind of fraught with error as well. Okay, so again, when we don't use body surface area, what's the most common thing we use? Weight-based dosing is the most common. Body surface area gets more complicated, but we use that more for like chemo a lot in pediatrics. Sometimes we use it for certain hormones and steroids and things like that. But for the most part, we're going to be dosing most things in weight-based doses. Okay. What's the collective name for a group of buzzards? flock, a pack, a wake, or a murder of buzzards? Actually, a wake of buzzards, which is kind of fitting, you know, based on them kind of circling around a corpse of an animal. I thought it was pretty interesting. What would a murder be? Yeah, murder of crows, right? So again, that is one I'm more familiar with. But all right. Tadalafil or Cialis is most likely associated with which characteristic? It's most likely to cause muscle aches, most likely to cause visual changes, can be used with nitrates, or it's the shortest duration of action. So these would be most associated with tadalafil. All right, yeah, so tadalafil is most likely to cause myalgias. Why is that? Not because it lasts a long time, but more specifically with its mechanism. What isoenzymes, which enzyme does this mainly affect? But the enzyme system that it's mainly affecting. PDE is phosphodiesterase, right? So they're phosphodiesterase inhibitors, right? Yeah, so 11 is the one that tadalafil will also have some interaction with, and so that's more likely to see myalgias associated with that because that's found in the skeletal muscle. Which one do you see more likely to see visual changes with? That's going to be with sildenafil because it affects what? PDE6. Actually, PDE5 is what we're actually using it for purposes of erectile dysfunction, also for pulmonary hypertension, but PDE6 is found in the eyes, and that's where you can see a lot of visual changes. Good. Has the shortest duration of action? Nope, has the longest duration of action, right? So you can get, again, one pill for the weekend, essentially. That's a pretty good duration of action there. And then can be used with nitrates. Which one could be used with nitrates? None of them really, right? So again, ideally, you'd want to give them enough time for the drug to clear before you would utilize a nitrate. So this one would have the biggest problem with that because you'd have to wait a while before you'd really have a chance to give it. So, 36 hours at least I'd wait before utilizing a nitrate. Because again, what's the big risk with giving a nitrate plus a phosphodiesterase inhibitor? Hypotension, right? Again, if they're already having problem oxygenating the heart due to angina and coronary vessel occlusion, this is not going to help that problem in that respect, right? Okay. Let's see. Which sedative agent can cause this side effect? This is also kind of a trivia. I don't know if I mentioned it in class, so it's kind of a little trivia bit. But I always like things that can change color of someone's urine or poo. That was good trivia. It's actually Propofol. So again, the Michael Jackson drug. Most people tend to know it. But yeah, so Versed, what do we use Versed for? Or midazolam. Good for seizures. We could also use it for what? Yeah, for sedation, as an induction agent, potentially for RSI. Etomidate, kind of the same thing there. When would you want to use something like ketamine? So if you have like an asthmatic patient, that would be a good one, right? Because again, it helps to with some bronchodilatory effects. It's good if maybe you had someone who's like really hypotensive potentially, because again, it helps to release those catecholamines. It's just going to have a nice effect there. Who would you not want to use ketamine in potentially? Yeah, elevated ICP. You worry about that kind of spike in ICP. What do we give to block elevations in ICP during intubation? Lidocaine, right? So if you have a head trauma or a traumatic brain injury patient coming in need to be intubated, you want to use lidocaine for that as pre-treatment, right? What's the problem with etomidate? That can cause that temporary adrenal suppression. So you want to be careful with that, especially if you're thinking like a sepsis patient who may be kind of their cortisol levels might be kind of depleted anyway. Like that can have some negative effects on their blood pressure control, things like that. So that can be a problem. And then propofol. biggest side effects you're going to see with that one are going to probably be hypotension associated with that. So that can be also, again, a problem if you have like a septic patient. But otherwise, very good for like procedural sedation, especially in adult patients. Why don't we like to use ketamine for adults? They're crazy. They have dysphoria, right? So when they wake up, they kind of have a bad trip. Come out of it, they become very agitated. Typically kids do a lot better with that. You just tell them to think about their favorite thing, like go play baseball or go hang out with Mickey Mouse, and they wake up and they had a great dream. You reduce their fracture, they're good to go. Usually adults, they tend to have a little bit more kind of psychological baggage associated with them. That's how I think about it. Propofol is a lot better drug for that patient. Okay. Yeah, so propofol can turn your urine green. My favorite urine color changing story, which I don't know if any of you guys have a story like that, but I do, is we have there's a drug we use sometimes for UTIs. It's a urinary anesthetic. Anyone know what that drug is? It's called azo, right? So phenazopyridine is a drug. It's an over-the-counter product, so you can purchase that pretty easily. A lot of people will self-medicate for that if they have a UTI or something to deal with some of that pain, discomfort associated with that. Anyone know what color changes your urine? Orange reddish kind of color, right? So the other thing you may not know is that in overdoses, you can actually find that drug will cause what we call methemoglobinemia. Anyone familiar with that? What does that change your color or the color of your patient to? Red. They kind of turn blue, right? So again, they kind of look like a Smurf because they have this high concentration of methemoglobin instead of oxyhemoglobin. That's going to turn the blood kind of this like chocolate brown sort of color, but it's going to turn the patient blue essentially. It kind of looks like a Smurf. And so what do we give to a patient with methemoglobinemia? Anyone know? Yeah, you give them oxygen for sure. But to reverse, you actually give them a product called methylene blue. It's actually a dye. So if you have a blue patient, you want to give them a blue drug, and they'll turn them pink again. Essentially, is how I remember it. But methylene blue, it being a dye, guess what? It turns your urine. Turns it blue, right? So again, so this lady had red urine, kind of orangish urine. She had a cath put in, so her collecting her urine in a bag, and she had orange urine from the azo she had overdosed on, and then we gave her the methylene blue to reverse the methemoglobinemia, and then that started coming out blue, so it ended up kind of causing purple urine to form. So it's kind of neat because you actually kind of see it coming out of the cath and kind of mixing. I was like, oh, it's very interesting. We're just kind of monkeying around with the color of someone's urine. Anyway, so what I find interesting is not for your guys' judgment, okay? So, all right. Which of the following is true of renal function in neonates? Cockcroft galt is the preferred formula to calculate function. Serum creatinine is falsely elevated for the first several days. Prematurity increases the function and quantity of nephrons, and then urine output is the least accurate way of measuring function. Which I think would be true. All right, so why is Cockcroft galt not used? Who's that better for? Better for actually like adult patients, like your typical like adult sort of patient, like that's going to be good for Cockcroft galt. As you get into kind of the extremes of age, that's where you're going to see Cockcroft galt kind of falls off a little bit. You're going to find there's other ones that are out there, like the MDRD equation is good for more elderly individuals, so they think like in the 70s and 80s and kind of beyond, like that's where like the MDRD equation kind of comes into play. A lot of patients, most adults can use Cockcroft galt, and that's a great equation for that. The problem is when you kind of get down to the very young patients, you find that formula has not really been validated for them. It does not work all that well. So again, when you have a neonate, again, that first month of life, typically we're not even calculating creatinine clearance because we don't have a really good equation to do that. And those haven't really been validated. For kids as they get a little bit older, we have a formula called the Schwartz equation, and that's what we use for pediatrics most likely. So you'll run into that if you do your peds rotation potentially. All right, so prematurity increases the number and quantity of nephrons. No, it's the opposite, right? So again, they're going to have more immature kidneys the earlier they come out. And how about urine output is the least accurate way to measure function? Actually, the most accurate way. So again, we're typically looking like an ml per kilo per hour or more is usually considered good urinary output. And again, we can measure diapers. They have cath in, you can measure that. So there's different ways to do that. And then serum creatinine is falsely elevated. Why is that? Actually, the mom's creatinine you're measuring there for the first couple of days. So until they kind of clear that out, and again, depending on how premature they are and how good their kidneys are functioning at baseline, it may take a little bit. But yeah, that is actually the mom's creatinine you're measuring there for the first few days. Good. All right. A patient is hypotensive and bradycardic. Which vasopressor would be best suited for this patient? Should we utilize vasopressin, dobutamine, epinephrine, milrinone? It's going to be good for this patient who's bradycardic and hypotensive. So think back to the mechanism, think back to the receptors they're interacting with. Your alphas and your betas and all that good stuff. Let's see. Right, epinephrine is a very good drug in this situation. So what does vasopressin do? It's another name for vasopressin. ADH, antidiuretic hormone. So that's really good for helping kind of maintain intravascular volume, usually used as an add-on sort of pressor. So you may see like patients on like epinephrine and Norepinephrine, and they're still not having troubles getting their pressure under control, like the sepsis patients. This is when vasopressin kind of comes into play, because usually those patients may have a deficiency of ADH in the first place, so this can help with that. So not a good kind of first-line pressor for those purposes. How about dobutamine? What does that do? It's actually a beta-1 agonist. So, okay, beta-1 agonist. So what do you think that would do for us? So it would actually be a positive chronotrope and an inotrope, right? So again, that helps to increase the speed of the heart contractions and the squeeze of the heart. So who would that be good for? Perhaps someone who has like poor ejection fraction, poor cardiac output, CHF decompensations, right? So this is a good case where you can use dobutamine. It's a beta-1 agonist to kind of help increase the squeeze of the heart to kind of get better cardiac output for those patients who are maybe having like an acute decompensation due to CHF, okay? And then milrinone, what does that do? Just that one briefly. This one's also a phosphodiesterase inhibitor, but again, you're not going to see it being used for erectile dysfunction because it interacts with PDE3, not 5. So PDE3 is going to, when you inhibit that, that's also going to help to increase the contractility of the heart by increasing levels of cyclic AMP. So that's good for that. It also is going to have some vasorelaxant sort of effects as well. So again, it's good for you have like a CHF decompensation where they're hypertensive and the cardiac output's kind of crummy. You can use this to kind of help increase the squeeze on the heart and kind of relieve some of that pressure a little bit on the blood vessels. So milrinone can be used again for those kind of decompensating CHF patients. Now epinephrine, on the other hand, what's that going to be affecting? Alpha-1 and beta-1, right? So those are going to be good things for our purposes for a hypotensive bradycardic patient, because that will increase heart rate, it will increase blood pressure. It also has some beta-2 effects as well, so again, it can get that kind of bronchodilatory effect, which is good for what type of patient? Anaphylaxis, right? So again, remember, those patients are usually having bronchoconstriction, they're having hypotension due to all the histamine release. You know, epinephrine is going to be kind of your go-to drug in those circumstances, right? So kind of think about what the activity is. You know, if you had someone who was, say, tachycardic and hypotensive, you'd want something that more acts on which receptor, beta or alpha? Tachycardic and hypotensive, you probably want more alpha activity, right? Because again, you want more squeeze on those blood vessels. So again, if you had a patient who, say, got nitrates plus Viagra and their blood pressure is bottoming out, you want something with more alpha activity. And so something like norepinephrine is better for that, or something like phenylephrine, because again, those are going to have better propensity to affect those alpha receptors. They kind of spare a little bit of the beta, right? Because again, the cardiac output's already fine where it's at. It just needs to have that pressure kind of built up there to kind of equalize things out a little bit. Make sense? Okay. I got no affirmatives for that, but I'm just going to assume that, okay, this will make sense when you have to review this later. So, all right. I believe in you guys. No. Patient with bradycardia undergoing intubation should receive which medication? Epinephrine, rocuronium, adenosine, atropine, which is going to be good for them. Because again, when you intubate somebody, what can that do to the heart rate? Yeah, vagal stimulation, right? So that helps, is going to cause them to brady down more potentially. They're already bradycardic. What can we give them? Atropine would be the correct one in this case. What does atropine do? Remember, it's a muscarinic receptor antagonist. So what is that going to do on the heart? Increase heart rate, right? So again, think bradycardia, think atropine is like your go-to drug for that, right? So that's going to definitely increase heart rate by blocking acetylcholine on those cholinergic receptors, muscarinic receptors, right? Epinephrine could increase the heart rate, but that's typically not a pre-medication we would do for RSI. However, you know, if the patient was like coding or something, certainly that would try to help with that, but that would not be our first go-to drug there. What does rocuronium do for us? It's actually going to paralyze the patient. So you're going to find that that actually would not have really any effects on the heart. Even though it is a muscle, it does not paralyze the heart. It only really affects skeletal muscle or the kind of voluntary muscles there. So rocuronium, is it a depolarizing or non-depolarizing neuromuscular blocker? It's a non-depolarizing, right? So what's our depolarizing one? Right, succinylcholine, right? That actually has the ability, because it's actually stimulating those receptors initially, those nicotinic receptors, and desensitizes them. Eventually they kind of wear out, and that's why you get that paralysis. You can actually find that patients getting kind of multiple doses of succinylcholine can actually break it down due to that, some of that kind of bleed over effect on those vagal receptors. So some patients will get atropine if they have like repeated doses of succinylcholine. That's one thing you may see there. But rocuronium really should have no effect on heart rate whatsoever, which is good. So that would probably be a preferred paralytic if I had already a bradycardic patient who was having to give atropine to. What else could atropine do for me? And especially like in case like intubation, what else could that be really useful for? What is atropine? What would it do to secretions? A decrease them, right? Yeah. So if you have someone who's having a lot of sialorrhea or someone's having a lot of secretions, you can actually try to dry someone out by giving atropine. That will actually help with that. So one thing to consider there. You remember any of the sedative agents we have that actually causes sialorrhea? Sialagogue, another name for that. Ketamine is actually the drug that does that, right? So again, can cause increased salivation, increased secretion. So maybe another case you might consider using atropine. And then adenosine, what do we use that for? SVT, right? Because that kind of just shuts down the heart for just a second, comes right back, and hopefully it's kind of you've broken that rhythm there, can go back into normal sinus. What's the thing with adenosine? What's the thing to note there? The administration of that drug has to be given very, very quickly because again, it's a very short half-life, less than 10 seconds. Good. All right. Which patient would produce the best response to an inactivated vaccine? Would it be a 14-day-old infant with no medical problems, 6-year-old male under active treatment for leukemia, a 26-year-old male with HIV/AIDS, or a 16-year-old female? Yep, so most likely you'd find the 16-year-old female and their other medical problems would be able to mount kind of the best response to that vaccine. Why would someone undergoing treatment for leukemia not be good? They're immunosuppressed, right? So again, we are trying to suppress that immune system as best we can because they have leukemia. So again, that would be unable to kind of mount a good response. How about someone with HIV/AIDS? Now, just because you have HIV, does that mean you're necessarily immunocompromised? Not necessarily. If you're really early on, if you still have a really good CD4 count, your viral load's being actively suppressed, you can still have a pretty competent immune system. But by saying they have AIDS, that usually means they have an AIDS-defining illness. That usually means they're pretty immunosuppressed for the most part. So if they're going to get their CD4 count low enough, or they're starting to develop like PCP pneumonia, things like that, like they're pretty well immunocompromised. So at that point, I'd probably consider them to be unlikely to have as good a response as someone who is, say, otherwise healthy, right? And how about a 14-day-old infant? Yeah, their immune system's not really that competent yet. So again, and that's again why they don't even receive live vaccines until they're 12 months of age, because why? They also have maternal antibodies that can actually, that passive immunity, that can actually inactivate those vaccines and kind of lead them to be less effective. So lots of reasons there for that one. Okay. Urge urinary incontinence in a 54-year-old female will be best treated with sulfenacin, tamsulosin, dutasteride, or sildenafil. What do we think? All right, so think about we have a 54-year-old female would be best treated with probably sulfenacin, which is what type of drug? It's an anticholinergic, right? So again, with these patients who have urge urinary incontinence, what's kind of their issue? Yeah, so it's probably either bladder overactivity or it could be potentially an issue with urethral underactivity, right? So the first line drug we're going to use to treat that is going to be things that affect the detrusor muscle. We're going to try to deal with that bladder overactivity. And so what usually stimulates the detrusor muscle to squeeze? Acetylcholine working on those muscarinic receptors. We're going to give an anti-muscarinic drug. So sulfenacin would be good here. Oxybutynin would be good there. Ditropan. Any of those drugs would be totally fine. So you got kind of a long list of them. They're good anticholinergic drugs there. That would probably be first line. Is there anything we could do to potentially increase that urethral activity for a female patient? You try like an alpha-1 agonist, but again, those have other problems like hypertension and stuff. Some people will try estrogens. Sometimes that can help to kind of increase the kind of cause the urethral cell hyperplasia to occur there. So that's one thing you may see kind of off-label use for estrogens. But this is the main thing, mainly anticholinergic. So why would dutasteride not be a correct answer? It's a 5-alpha reductase inhibitor, right? So that would be affecting mainly what organ? The prostate, right? And again, females typically have how many prostates? Usually 0, right? So that would not be a correct answer there. How about sildenafil? Again, similarly, it's not going to be a really good treatment for that necessarily for like guys with BPH, but sometimes it's a good adjunct if they have an additional like erectile dysfunction in addition to BPH. So sometimes you get some additional benefit there because it can kind of act as a smooth muscle relaxant for the prostate. So not a great option here. And then tamsulosin is going to mainly do what for us? Yeah, it's an alpha antagonist. If anything, that would actually decrease urethral squeeze, and so that actually could lead to worsen effects there if that was their kind of issue. And again, more often you're going to see this for like BPH purposes, right? So yeah, so sulfenacin, the anticholinergic, is going to be the best option for that. All right. Patient with history of malignant hyperthermia can safely receive which paralytic? Vecuronium, cisatracurium, rocuronium, succinylcholine. Which one can they get? All right, 3 correct answers for this one. Again, no trick questions on the test, but I can trick you all I want here. Right, so what's the key issue with this? Cannot receive succinylcholine. If you have a history of malignant hyperthermia, this could interact with that, right? This will also come up in the surgery section, coming up a little bit later. When you see inhaled anesthetics, like general anesthesia, those are also drugs that can potentially cause malignant hyperthermia. So we do not want to give succinylcholine if we have that history. However, any of the non-depolarizing neuromuscular blockers are totally fine. So vecuronium, rocuronium, cisatracurium, those are all totally fine to receive, okay? What is the drug we give to treat someone with malignant hyperthermia? Dantrolene, right? So it's actually a peripheral muscle relaxant, right? Because again, the issue with someone who has malignant hyperthermia, their muscles get overly activated, they get very tight, very rigid, they produce a lot of heat, a lot of acid, so it can go downhill pretty quickly. So you can give dantrolene to kind of relieve that muscle stress there. Good. All right. In elderly patients, which of the following would be considered intelligent non-compliance? I think you have sweet grandma SquarePants there. So it would be forgetting doses secondary to Alzheimer's, applying a second patch while the first one is still attached, taking a BID medication daily to save money, or not being able to swallow tablets due to dysphagia. The intelligent noncompliance. Yep, pretty straightforward with that one, right? So you have to think about, like, if you have a patient who's kind of doing one of these kind of methods of like intelligent non-compliance, if you ask them like, hey, are you taking the medications like I told you, like, what are they gonna say? Yeah, of course I am. Yeah, of course I'm taking like, and then so you're kind of like, well, why is your blood pressure not under control? Why is your sugars not under control? So oftentimes you need to kind of try a little bit different line of questioning. Like oftentimes I'll try to have patients tell me like, well, how do you take your medications, right? And that way they kind of have a harder time kind of, you may slip up a little bit or something, maybe to catch them in a lie. Because again, they may try to tell you what you want to hear. There's no maliciousness there. It's just, they don't want you to kind of come down on them with any kind of judgment or anything like that. Not that you'd ever be judgmental of your patients, because again, everyone leads a different life than you, so that's okay. We need to be curious and not judgmental, as they say. However, for getting doses secondary to Alzheimer's, certainly another form of non-compliance, but not really their fault, right? So again, it's just going to progression of disease there. Applying a second patch while the first one's still on, more common than you might think. And again, if you ever have someone who's like coming in, say like to the ER, and you're worried about drug toxicity, one of the things you really want to do, especially in these elderly patients, is make sure you're checking them for patches, right? And so you need to do kind of a full body scan, get their clothes off, look all over, because again, if you miss something like a fentanyl patch still being on a patient with chronic pain, that can be a leaching drug for a good long time, and can lead you to have more toxicity than needed. And obviously not being able to swallow pills, that's not really, a problem that they're doing on purpose by any means, but what could you do in that case? To switch like liquids or something, right? So you have to kind of work with your patient to try to make sure they are kind of set up for success based on dosage forms and dosing regimens and things like that. Okay, let's see. What is the maintenance fluid rate of normal saline for a 23 kilogram patient? How much normal saline would you give them per hour? So what's our rule here? So there is math on the test, but it's pretty easy. Don't need a calculator. Should be able to do basic multiplication and division. Should be pretty easy. And you guys are already experts at this anyway, because you've done so many prescriptions now, right? All right, so how do we get the answer to this? What's the rule? 4, 2, 1. All right, so 4 mLs per kilo for the first 10 kilograms. We get 2 mLs per kilo for the second 10 kilograms, and then 1 ml per kilo for every subsequent kilogram. Okay, so for a 23 kilo patient, they'd be getting how much? So 40 for the first 10 kilograms, right? 20 for the next 10 kilograms. So already we're at 60, and then 3, right? So 63 mLs per hour would be the correct answer in this case, right? Now, would it be dangerous to give more than that? Not necessarily. You can do sometimes if they're really dehydrated, you can do 1.5 maintenance rate. You can do 2 times the maintenance rate. This is a general rule of thumb, though, right? So again, you can't really go wrong by giving them this amount unless they had like renal disease and they're really kind of edematous to begin with if they're fluid overloaded. But what would 460 be? That's actually the fluid bolus, right? So 20 mLs per kilo is a typical fluid bolus for those patients, right? And actually, I had someone who was on rotations that came by during their EOR, and they're like, we had this renal patient, and they seemed dehydrated, but we weren't sure how much fluid to give. So, and whenever you're dealing with a renal patient, who you need to give some volume to, just go with half, right? So again, for a renal patient who maybe missed dialysis or something, you can give them 10 mLs per kilo as a bolus, and you typically won't run into too many problems with that, unless as long as their lungs sound clear and whatnot. But again, you can always give more fluid. You can't take it back, right? Unless you got a dialysis machine ready to go. Okay. What's the collective name for a group of frogs? A maelstrom, a quiver, a nest, or an army? Don't feel bad. I barely remember the right answer, and I looked it up last night. It's actually an army of frogs. What do you guess? A maelstrom was actually for salamanders, if I remember correctly, because I thought it was the coolest one. So if you ever have a maelstrom of salamanders, you're goofed up in life at that point, right? Nest would be for what? Usually a nest of snakes. I'm trying to go with like kind of a theme of animals here, so this is the amphibian / reptile category. But anyway, all right. Pete's priapism, that sounds very inappropriate. Okay, and the old which system keeps most of its activity, but drug-drug interactions are more likely? Which organ system typically retains most of activity, but you're more likely to see drug-drug interactions? I had very limited character count, so I was trying to write this out as succinctly as possible. So in the old, an elderly patient, right, which organ system maintains most function, however, you're more likely to see drug-drug interactions? So we talked about all the different organ systems that are important for drug metabolism, excretion, distribution, all that good stuff. Which one typically retains most activity, however, drug-drug interactions are much more likely. In hindsight, probably not the best question, but again, limited character count, so. Yep, so the GI tract's probably the biggest thing with that one, right? So GI tract typically maintains most of activity. You may see like some slow GI time, transit times depending on disease states and whatnot, but typically everything's kind of working there, right? But again, drug-drug interactions are huge, especially when you think about their diets like, if you think about, things that are binding up other medications, because again, older patients typically need what element in high amounts? A lot of for the bones, calcium, right? So then you like calcium, like that binds up with a ton of different drugs, right? They're on iron supplements, they're on antibiotics, like all those things can potentially bind up with one another. A lot of drug-drug interactions you have to worry about. Think about your bisphosphonates, right? You have to give that on a completely empty stomach because the bioavailability is so poor to begin with. But everything else tends to take a hit. So for instance, the liver typically going to see less function, functions are going to decline. Certainly still see drug-drug interactions, but typically you're going to see kind of lessened liver function over time, which can also be problematic. Kidney function obviously goes down. Pancreatic function, not really important for our purposes for kind of like drug metabolism and excretion, but anyway. Okay. All right, patient's 23 kilograms. The drug is amoxicillin, 80 milligrams per ml. The dose is 90 milligrams per kilo per day. BID, what is the volume of that dose? Again, limited character count. I was trying to write a lot with little space. So it's 23 kilo kid. They're getting 90 milligrams per kilo per day divided BID, and the amoxicillin is 80 milligrams per ml. What volume should they get? Someone already answered, they just knew instinctively, yes, this is the right answer. I applaud your gusto. The math will be easier on the test than this, just FYI. But since you have access to calculators, then use them. All right. Yes, the correct answer is 13 mLs per dose. All right, how do we get that? It's our first step. All right, so we're going to do 90 times 23. What does that give us? All right, let me just do it here. Let's do calculator. All right, so if we do 90 times 23, it's 2,070. That's what they should be getting per day, right? So that's what they're getting per day. So we can divide. We want to figure out what they're getting per dose, though, right? We want the volume. So we divide that by 2 because they're getting it BID. So we divide by 2. So they're getting that dose, 1 gram, essentially, per dose, right? So now what do we do? Divide by the concentration, right? So again, your milligrams should cancel out, and you have mLs left over. So we're going to divide that by 80. Boom, we get 12.9 mLs. You can round that to 13. That's totally fine, right? Make sense? Yes?
How do you word it so I know whether or not you divide it? Like, how do you...
So,
sometimes it says dose,
sure.
sometimes it says BID. Like, I don't understand.
Right. So when you say 90 milligrams per kilograms per day, that means that's the total amount they're getting in a day, right? If it says BID, then you know you're getting that dose twice a day, right? So then you know, okay, well, they're getting this total amount, then it has to be divided by 2, right? Because you know they're getting twice a day. Versus if it was TID, now just say that 90 divided by 3, and then I have 30 milligrams per kilo per dose. Okay? Yes?
But there was an example in the PowerPoint where you said something along the lines of like 90 milligrams per kilogram BID, and you didn't divide it by 2.
Right. So if I say 90 milligrams per kilogram per dose,
Okay.
then that would be, they're getting that dose each time, right? So that's the thing you have to watch out for, because again, you're going to run into mixed, mixed units when you're kind of going through and dosing things for patients. So again, when you're looking at those references, does it say milligrams per kilo per dose, milligrams per kilo per day? Because that makes all the difference, right? So you can very easily either triple someone's dose or give them a third of what they need or double it. So again, be very careful when you're looking at that stuff. We run into those issues with some regularity, okay? All right. All right, patient in VFib, cardiac arrest, has not responded to defibrillation, the electrical means. Which med can be used? So you see that on the monitor, and you're saying, uh-oh. What do? You give adenosine, digoxin, lidocaine, amiodarone. You guys get a whole lot of this week, right? You guys doing trauma survey or something? You guys will do like the ACLS stuff later, though. But you'll get pretty well acquainted with this. Again, my EKG skills are not stellar, but at least I can look at that and be like, that's bad. No bueno. All right. So what do we use digoxin for typically? Yeah, more for AFib, but again, not going to be like in an emergent case like this, you would not really kind of bust out digoxin. This is more for kind of chronic management, but more often than not, we use digoxin nowadays for what? You do for CHF, right? So some of those neurohormonal effects you can get out of digoxin. Adenosine is going to be for what? SVT, right? So again, those are going to need to be kind of atrially derived arrhythmias that are happening here, because again, you have that very rapid conduction down to the ventricles. So again, this would not be necessarily, this is not the case there. It's just purely in the ventricles where the arrhythmia is happening here. Lidocaine could be a correct answer in this case, and actually back in the day, the guidelines would probably say lidocaine was a good choice there. However, it's now being supplanted mostly by amiodarone. So amiodarone is like kind of your go-to drug for ventricular arrhythmias. You could also use it for atrial arrhythmias. So if I had someone with SVT and they failed adenosine, did not respond well to that, I could actually give amiodarone, and that could still potentially have some activity there. Because anyone remember what class amiodarone is? Class 3, right? So a lot of different activities there, but mainly the big thing is blocking the potassium efflux, helps to kind of help that refractory period, extend that somewhat, helps to kind of reset everything. So again, amio is a really good drug for that case. VFib, not responding to electricity, amiodarone is a good go-to drug. Okay. All right, where should you go? Let's see, where should you go to get up-to-date vaccine recommendations? The Centers for Disease Control, the Florida Department of Health, Infectious Disease Society of America, or American Academy of Pediatrics? So what is the vaccine schedule for this 6-year-old? Where do I go? Yes, CDC will be the correct answer here, right? So you can always go to CDC to get the most up-to-date. When do they put out new vaccine schedules? January. Every year in January they put out a new vaccine schedule, so you always go get the up-to-date stuff there. Department of Health might have some good local kind of things. So if you're worried about like rabies prevalence in the area, like that might be a good place to get information like that. The IDSA is good for like infectious disease guidelines. So if you're worried about like treatment for pneumonia or treatment for X, Y, and Z, like IDSA is really good for guidelines from there. And then AAP is good for more pediatric illnesses. So like if you look up like otitis media guidelines or you know, strep pharyngitis, things like that, they'll put out some guidelines there. But CDC really can't go wrong going there for vaccine recommendations. All right, it's always good to know what your resources are. All right, which of the following could cause erectile dysfunction by blunting responses to external stimuli? So it has more to do with like drug-induced causes for erectile dysfunction. Say, for instance, an attractive individual showed up, what would blunt that response to having that reaction to an attractive individual? Maybe you see a consortium of crabs and like that's something you find interesting. Or an army of frogs. No shame here. Actually, would be lorazepam. So why do you think lorazepam's the right answer? Causes sedation. Yeah, if you're too sedate to actually respond to any kind of external stimuli, so like, you know, some of these patients get so sedate they only respond to like, you know, deep sternal rubs and whatnot. Like they're not gonna be able to develop an erection in response to any kind of external stimuli, right? How about spironolactone? What would that cause issues with? Nah, it's not really that potent of a diuretic where you'd see like decreased blood volume causing an issue there, but more likely is due to some of the testosterone inhibiting sort of effects there, right? So maybe decreased libido related to that. Finasteride would do similarly because it would cause decreased production of DHT, right, which could affect your libido. So again, that may kind of inhibit kind of, you know, internal sex drive, but not really, you know, response to external stimuli. And then alfuzosin probably wouldn't have any really effects probably at all, because again, pretty specific for working on those alpha-1 receptors there for BPH, right? Good. But any kind of sedating drug I could have put on here, so I could have put alcohol, I could have put, you know, antipsychotics, anticholinergics, like anything that causes sedation could potentially do the same thing here. So it's one thing to consider. Okay. Patient with SVT that didn't respond to adenosine could use which med to control their rate? So again, it's not rhythm, but rate we're controlling. They're saying this is arrhythmia just does not respond to anything. Let's just try to slow down the ventricular rate, try to establish good flow, good perfusion. All right, so amiodarone would not be correct in this case because what would amiodarone do for us? It would actually try to correct the rhythm itself, right? So it actually doesn't do a whole lot to heart rate necessarily, unless you gave too much too fast, you can potentially see some bradycardia, but that would not be the case here. And again, right now, all we're trying to do is really, if you have SVT, we're trying to slow down the conduction between the atrium and the ventricles, trying to slow down so that way the ventricles can still pump with some regularity, because you can still have some degree of efficiency in perfusing the body, right? That's the main thing we're doing here. Amlodipine would not be good, because what would that do? Only cause hypotension, really, if anything, right? However, what other types of calcium channel blockers could I have used? Cardizem or diltiazem or verapamil, right? So non-DHPs would actually be correct in this case had I put that there, right? How about norepinephrine? What would that do for us? if anything, increase heart rate, because again, this has good alpha activity, but it still has some beta activity as well. So you still see some beta 1 agonism there. That would not be correct. However, a beta blocker is absolutely right in this case. You can actually give esmolol as a continuous infusion, helps slow down the rate, and kind of get you, buy you some time until you can kind of figure out what's going on with their arrhythmia, right? So again, this is a form of rate control, not rhythm control. All right. Which patient can safely receive a succinylcholine? This goes back to their contraindications. They have a crush injury that occurred 3 days ago, spinal cord injury that occurred 3 hours ago, severe burn that occurred last week, or hyperkalemia and renal failure. Which one would be safe to receive succinylcholine? Probably scared you guys enough. No one's ever going to recommend succinylcholine in their life, right? It's like they say, sucks, sucks, and rock rocks. So most people just go with rocuronium. All right. So what's the issue we worry about with giving succinylcholine to like some of these like crush injuries, burn injuries? You see upregulation of those nicotinic receptors, and the more that succinylcholine interacts with, the more it's going to cause what electrolyte to shift? Potassium, right? It's going to shift more potassium outside of the cell. You see hyperkalemia, that causes arrhythmias, right? That's no good. We don't want that to happen. So, and again, it takes time for those receptors to upregulate. So, for instance, if they only had an injury 3 hours ago, spinal cord injury, that's not enough time, right? They need like 48, 72 hours before those really start to get upregulated. So, you know, crush injury 3 days ago, absolutely would not give succinylcholine, right? Hyperkalemia, obviously no, because we said that's the main problem we're trying to prevent. And severe burn that occurred last week, again, they would still be upregulated, would not give in those cases. Make sense? So again, keep those contraindications in mind, because again, when you're trying to intubate somebody, like, you know, you don't necessarily have time to, you still need to make time to think through all this stuff, and that's why they have like checklists and things like that, that we can go through it very quickly and say, okay, yes, they're a candidate, or no, they're not, and go with something else like rocuronium typically. Or in most cases, what newer people do, they just say, screw it, and let's just do rock for everyone. Okay. Again, not everyone in practice is like that. Typically, older practitioners, they typically still stick with succinylcholine. Right. Which of the following is not a current route for vaccine administration? Intramuscular, intranasal, oral, or rectal? Last few holdouts are just like, trying to see this one or this one. Yep, rectal is actually the route we do not have any current vaccines for. We do have oral. Anyone know any oral options? Oral polio, and there's rotavirus as well. Yeah, I think there's hepatitis ones that are kind of oral as well. But yeah, what's the most common one though? Yeah, intramuscular is going to be the most common one. Intranasal, we have the live attenuated flu vaccine, which again is not being recommended too frequently for these couple of seasons. But yeah, so rectal will be the only route that is not available. So let's see. This is our last question. What's the collective name for this animal? Glad we get to end on a fun one. For these lemurs, is it a conspiracy, a gang, a parade, or a leap of lemurs? I like to say a conspiracy of PA students, but. It's actually a conspiracy of lemurs. I thought people would go for that one. It's the most kind of provocative sounding. All right, who's our winner? Our winner is Jubs. Who's Jubs? Fantastic, good job, sir. Pete's priapism. Oh, very provocative. And legalized skooma. Very nice, very nice. All right, so your free answer, actually this time, G. Okay, no, it's a good B. All right, so any questions for the test? It's going to be on Monday. Any questions, please email me if you think of anything. Have your prescriptions turned in by then. Anything else? If not, I will see you guys next time.